وين منين؟ Okay, تمام, excellent. Merci. Good morning, everyone, and good morning, my dear professors and all our lovely visitors. Today I'll be talking about the role of integrated anatomical and molecular imaging in common types of dementia. Starting first, that we have to all agree that dementia is a clinical syndrome, and it's an umbrella term that describes a collection of symptoms that are caused by disorders that are affecting the brain. Dementia is usually preceded by mild cognitive impairment, which is the point that we need to identify the patient at this level. This is cognitive decline, which is greater than the expected for age, but not interfering with the activities of daily living. However, MCI has its importance because it does progress to dementia in 10 to 15% of patients annually, and these cases of dementia are absolutely incurable. In patients who present with cognitive impairment, obtaining MR appears to be the standard practice. However, the addition of PET-CT, addition of PET-MRI or PET-CT will definitely strengthen the interpretation. So let's see how dementia becomes full-blown. It starts by mild cognitive impairment, moving on to mild dementia, moderate dementia, and then severe dementia. If you look at this, you will find that it appears to be a continuum of cognitive impairment, where how can we actually diagnose early cases of dementia, which is the point that we are looking on in the future now. We're not trying to identify the structural changes after the patient has already established full-blown dementia, but however, we're trying to identify the earliest stages where this does not still interfere with the patient's daily activity. So at first, it's a clinical diagnosis by identifying the cognitive complaints, and then screening phase where the cognitive screening based on the individual patient case, and then we move on to the clinical assessment, and this is where we as nuclear medicine play the great role in the biomarkers of Alzheimer, and then we initiate the patient care, which is usually tailored according to each case. So now we have currently the CSF biomarkers, which is still an invasive technique, and then moving on to the blood biomarkers, which is still an invasive technique. However, when you look at the imaging biomarkers and the lovely appearance of these images on PET with amyloid as well as tau and FDG, and then combining this with or integrating this with the CT or MR, this is what we are going to talk about in details. So, what's the clinical significance of molecular imaging? Let's take every tracer separately. First of all, if we're talking about PET in general, why are we using PET in dementia? Because this will help to detect the pathophysiological changes, as we have mentioned, decades before the symptoms appear. And this is what we are aiming for. So let's take every tracer separately. Amyloid PET leads to a significant change in the diagnostic certainty and patient treatment in around 20 to 60% of patients. Then tau PET will help us or will aid us in predicting the clinical progression and will also help us to stage the disease process. Dopaminergic imaging, which is mainly directed to the assessment of the integrity of the nigrostriatal pathway in Parkinson's syndrome. And then there are newly arriving tracers that are mainly used for detection of neuroinflammation and to detect as early as the inflammation of the astrocytes. That will act as a body's defense mechanism against the full establishment of dementia, as well as the deposition of the amyloid. When you look at these images, which is very nice, the first image over here, this is the amyloid image, and you can see here that I will show you later the normal one, but however, in this patient, he had a very high amyloid burden, as you can see in the first image. And then when you look at the tau, you will find that there is also some tau deposition or tauopathy within the brain. And then looking at the normal FDG PET that we are all used to, you can see that, on the contrary, the presence of the disease process will appear as an area of hypometabolism rather than an area of increased tracer uptake, which is totally different than how we do interpret amyloid and tau PET. So let's take every tracer separately just to make it more clear. FDG PET, you can see in the first image, this is a normal brain PET where there is high cortical uptake throughout the brain because, as we know, the brain is working all the time and it's consuming the glucose, and this is why it appears very high uptake diffusely. When you look at the second patient, you find that there is this is an advanced case of Alzheimer's disease where there is cortical hypometabolism in the frontal as well as in the parietal lobes. And you can see that there is a small stripe of high uptake which represents the preservation of the motor stripe, which is very classic for Alzheimer's disease. So as we all know, PET creates the brain metabolism map. Moving on to the second tracer, so just keep the scan in your mind, and how do we see the appearance of dementia on the FDG. Moving on the appearance on the amyloid PET, you can see that amyloid positive early Alzheimer will usually precede dementia onset by 15 to 20 years. So you can really understand why we are trying our best to move on forwards in these traces, because you can detect disease process like 2 decades before. So amyloid negative PET scans, on the other hand, it usually rules out, if the patient is having an amyloid negative scan, then it rules out the presence of dementia at all or Alzheimer. Increased cortical uptake are abnormal, and this is what we have mentioned before, that it's on the contrary to FDG PET, that you have the uptake appears to be higher. On FDG, it's hypo. An internal control in the amyloid scans appears to be the cerebellum, as you will see in the next slide, where you can see here that this is normal amyloid uptake. The classic feature is that the white matter appears to show high uptake within the amyloid scan, which is normal. However, in the cortical areas, there is no uptake, and this is how a normal amyloid scan appears. And then you look at the second image, and you can see that the cerebellum is totally spared in this image, and this is the control in cases of amyloid PET. Let's take examples just to make it more clear. This is a patient with normal amyloid uptake. This is a 65-year-old woman who is presenting with mild cognitive impairment. And then when we used amyloid PET, we can see that there is normal white matter uptake within the brain, and the cortex appears to be spared, and this finding definitely rules out Alzheimer. So this is a normal patient. When we look at the second patient, you can significantly see the difference between the two pictures, where you are not able to identify the gray-white matter differentiation, and this means that there is high amyloid deposition. And this is classically a case of Alzheimer. The distribution of this will help you furthermore identify the stages of the disease process. So as we have mentioned, we are trying to identify Alzheimer as early as 2 decades before the establishment of the disease process. And this is furthermore classified into mild cognitive impairment stage 1, mild cognitive impairment stage 2, stage 3, and then the patient develops the full-blown Alzheimer on the last row on the right. So as you can see here, the red color or the red coding appears to increase as the patient gets worse, which is, on the other hand, if you are interpreting a glucose FDG PET, classically it will appear as areas of hypometabolism. Let's move on to the third tracer that we are using as a biomarker now, which is imaging biomarker, which is FDG DOPA PET. The agent allows the visualization of active synapses in the corpus striatum. So what we're trying to visualize in these are the integrity of the nigrostriatum. So what happens in the disease process or in the pathophysiology is the presence of Wallerian degeneration of the dopaminergic neurons. And so the tracer will not become taken up within the region of the nigrostriatum. And this will lead to the damage of the region of the basal ganglia as well as the visual cortices. You can see here a patient with Parkinson's disease, and on the other hand side, you can see the classic coma appearance of the region of the basal ganglia, and you can see here that FDG DOPA will allow for the measurement of the DOPA decarboxylase activity in the nerve terminal, which is usually decreased in these cases. We do have another technique, which is the Dat Scan, which I think all of us are acquainted with, but you can definitely see that there are many factors that will make F-DOPA PET, which is appearing to be much more advantageous. So the F-DOPA PET will have a higher resolution, as you can see in the images. It will have accurate measurement of the dopamine activity, and it's definitely a faster scanner, taking around 1.5 hours to be completed, with comparison to a Dat Scan that will take up to 5 hours. Last but not least, it was identified that the dementia with the Lewy bodies will have 2 main features. It might be amyloid negative and it might be amyloid positive. And at this point, you can actually be able to identify the difference between both types by using the FDG DOPA. So in the first row of images, you can see that this is a normal control, where this is an amyloid negative scan. If you look at the image over there, this is an amyloid negative scan, and then you can see that this is a normal FDG DOPA scan, okay, with the normal coma appearance of this region. And amyloid negative, on the second row, you can see that this is a patient who is showing some uptake, higher uptake in the region of the frontal and the temporal region. And you can see, if you correlate with the dopaminergic imaging, you will find that there is low uptake as corresponding to the first case. So we do have two categories of dementia with the Lewy bodies without getting into details, and dopaminergic imaging will help us identify the difference between them. Moving on to the fourth tracer, which is tau-based PET, and just to identify what are tau proteins will stabilize the neural microtubules in the normal brain. Tauopathies are mainly identified as frontotemporal lobar degeneration. This is one of the major examples of tauopathies in neurodegenerative disease. However, Alzheimer as well will have some degree of tauopathy, because it was discovered that this amyloid deposition within the brain usually encourages even the deposition of what is called the misfolded tau proteins. So you will find the uptake of the tau as well as the amyloid in cases of Alzheimer. And this will have even more categorize these cases. So just to move on and to make it a little bit clear, remember that the amyloid plaques are usually identified in between the neuronal fibers or the neuronal cells. However, if you're looking at these misfolded tau proteins, but they are seen within the cell itself. So we're looking at the neurofibrillary tangles that are formed in the disease process inside the cell, and the amyloid plaques are usually identified outside. And the presence of amyloid plaques usually initiates an inflammatory process that will usually lead to accumulation of tau as well. So let's check how the tau images they look like. In the first image, you can see that this is minimal radiotracer uptake within the brain in a normal individual. On the other side, you can see that there is high uptake noted within the right parietal region, and this was a patient who was presenting with mild cognitive impairment. Tau PET, however, has another application, which is the identification and the segregation of different types of Alzheimer. We can see that there are different types of Alzheimer. We all know the classic distribution of Alzheimer. However, getting more deep into this disease process, you will find that there is a limbic predominant Alzheimer, where you can see here that the uptake is mainly noted within the mesial temporal lobes. And then when you look at the typical Alzheimer, you can see that there is retention in both mesial temporal lobes as well as the neocortex. And then when you look at the third type, which is the hippocampal sparing type, you can see that it's mainly recognized within the region of the neocortex, with the sparing of the region of the hippocampus. With the region of the mesial temporal lobe. Imaging, fifth and last way of identification regarding nuclear imaging of dementia, you have the neurofibrillary and the synaptic density. As we have mentioned, neuroinflammation is an active role in the pathogenesis of different proteinopathies. However, neuroinflammation is already a process where the body starts to defend itself against the deposition of amyloid. So it was found that the detection of this astrocytosis or neuroinflammation can be noted by PET, and especially in cases of amyloid, where you can see that this patient does have an amyloid burden in the brain, which is very minimal, but they are totally normal clinically. And this is another patient who is having an amyloid positive scan, and he is definitely having mild cognitive impairment with an advanced form. So we can still find some amyloid traces, and this is what we're talking about with this, which is the neuroinflammation can occur before the significant amyloid deposition in the brain, and this may have a neuroprotective effect. So this patient may actually revert back to normal without the progression in the disease process. Let's take some classic cases for the different types of dementias. This is a case of Alzheimer, where in structural imaging you're not able to identify, apart from some brain atrophy, which is mild to moderate, as you would classify it. And then when we look at the FDG images, you can see that there is a classic appearance of the region of the markedly decreased activity within the bilateral frontal, as well as in the precuneae. When you interpret this with a further more sophisticated tracer, which is for amyloid, you can see what we have mentioned at the beginning. Is this a normal amyloid scan? The one, is it? So we have mentioned that the amyloid scan, to be normal, we have to see the gray-white matter differentiation. We're not able to see that in here. You can see that the entire brain became like one portion. There is no white matter differentiation from the gray matter. And this is a grossly abnormal finding with a very high burden of amyloid in the brain. Dementia with the Lewy bodies, this is usually in the structural imaging. You are only able to identify this person after he has a full-blown picture of dementia with the generalized volume loss and the significant occipital lobe affection. When you're looking at the FDG PET involvement, you're looking at the uptake in the brain, and as we have mentioned, this is a classic appearance of the posterior cingulate island sign, which is classic for DLB. In frontal lobar degeneration, there is moderate atrophy in this case, where you can see that the atrophy is mainly affecting the frontal lobes, and it's more affecting it on the right. When this patient performed the CT scan, you can see the full-blown picture in the temporal lobes with the widening of the temporal horn, and follow-up CT after 5 years would show you the classic appearance of FTLD, which is the asymmetry of the disease process and multiple areas of affection. Correlate this with the FDG PET, you will see that there is decreased activity in the frontal and the temporal regions finding, which is compatible with FTLD. So let's review the scans just to get out of this lecture being able to identify what does each tracer look like on its PET scan. In the first patient, you can see that there is hypometabolism is noted within the posterior region, as well as some hypometabolism within the frontal, and this is classic for a case of Alzheimer. What is this scan? It is an FDG, okay? And in FDG, you will see a hypometabolism of the uptake. Remember, it's glucose. In FDG PET of a clinically normal, on the other side, which is B, this one, you can see compare and contrast, and you will find that this is a normal FDG scan in a normal patient. Moving on to the structural imaging, you can see here that there is definitely a brain atrophy. And when you're looking here, this is another control patient for just comparing and contrasting. MRI of clinically normal 71-year-old woman, this one, and then moving on to the last tracer, which is here, E and F, just to compare and contrast how a normal amyloid scan would look like, where there is mainly uptake of the tracer within the white matter, but the gray matter appears to be spared. In this patient, you're not able to identify the difference between the white matter and the gray matter, which indicates that this patient has a high burden of amyloid ligand. So let's make it a little bit easier and back to our clinical and radiological evaluation. So how does this patient workup is done and the algorithm, and what are our recommendations as nuclear medicine studies? So the patient starts with the neurocognitive deficit, which is usually detected by the clinician. So the clinician will definitely order an MRI. And this MRI might show you some anatomical imaging changes. For example, this patient might have simply a space-occupying lesion that is causing something within the brain and leading to this cognitive impairment. Simply, this patient may have normal pressure hydrocephalus, which is one of the treatable causes of dementia, and therefore it has to be identified very early. So if a specific diagnosis is found, then it's fine. Treat the patient and treat the alternate etiology, which is the cause of dementia. If we were not able to identify anything on the anatomical imaging, then we have to move on to intermediate. If these findings are intermediate, then we move on to re-reviewing and revisiting the clinical history again. If we do find any findings that are related to Parkinson's, such as the presence of tremors or anything that is suggestive, then we go for what we have mentioned as the Dat Scan and preferably an F-DOPA scan. If it's positive, as we have said the findings, then this is a case of Parkinson and there is no further imaging performed. However, if we have reviewed the clinical history of the patient and we were not able to elucidate any findings that are suggestive of Parkinson, then we need to move forward to FDG PET, just to identify the areas of hypometabolism that could suggest the fingerprint of the specific type of dementia. So if we do an FDG PET, if you find the classic neurodegeneration pattern with the areas of hypometabolism that are consistent with DLB or Alzheimer or FTLD, then the diagnosis is made and there is no need to move forward. However, In some cases, we need to move forward to more advanced traces, which are, as we have mentioned, the amyloid and the tau, and this is usually done because of troubleshooting. We're not able to identify on an FDG PET what is the problem. So we move on to amyloid, and at this point you can identify that there is white and gray matter dedifferentiation, and this would suggest also the distribution of the Alzheimer or identify the type of dementia. So let's see how much you concentrated in this talk. Can you name the scan? Of course, all of us know the first row. This is an MR. Okay, so this one. So this is an FDG PET scan. And the next row appears to be an amyloid PET scan, as we have mentioned. And then this is a case, the last tracer is the tau PET. So this moves me to the end of this talk, where I will end it up with a very important classification and scoring system, which is based on the tracers that we use in nuclear imaging for the assessment of neurodegeneration, which is the ATN scoring system. The A refers to the amyloid positivity, where you can see in the second row there is a high amyloid burden, and the N refers to the neurodegeneration, which is usually referred to by neuronal damage on FDG PET with areas of hypometabolism. On A, it refers to amyloid uptake. So always remember that you look at the three, and thank you very much. This was a case of Alzheimer's disease with the distribution, and thank you.